The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to the Oregon EMS and Trauma webinar series. Thank you for joining us today. Let's see if I can get my screen view over to full screen. Well, it's not going to recognize my second screen, but we'll go through it this way. It's pretty easy for you guys to see, I think. So again, thank you for joining us today for going over emergency care for transgender patients. It's hosted by Taylor Sprecher. He's an EMT for AMR here in Clackamas County, and he also owns Taylor's Transgender Patient Awareness training company that he started. My name is Rebecca Long. I'm your host today. A few housekeeping details. Don't forget, at the moment, everybody is muted to preserve sound quality, but we encourage you to send your questions to the question box throughout the presentation, and Taylor will answer them throughout the presentation. For attending the webinar live today, EMS providers are going to receive 1 hour of continuing education. When the webinar closes, the follow-up evaluation will open. Please complete it to receive credit. If you do not see the evaluation right away, it will be emailed out 1 hour after the webinar with your certificate. Please note if you're viewing the webinar as a group, follow the instructions given to you in the survey. Certificates for group members, group participants will be emailed out the following week. Upcoming webinars. Don't forget, November 12th, we're going to go over infant safe sleep with Dr. Paul Rosticus. He just hosted recently for us, which was great. That class will count for obviously pediatrics and OB, miscellaneous EMS topics, and education topics approved by the medical director. And December 10th is going to be our annual 2019 trauma update with our EMS medical director, Dr. David Lehrfeld. So tune in for that. You guys noticed we had some questions this time, some different questions when you signed up for the webinar, which I thought were kind of interesting to get us kind of a baseline of information going forward. So one of the first questions was, have you ever treated a transgender patient? And as of this morning, about 9:30, when I tabulated the results for who signed up for the webinar, we had 156 people registered, and a pretty even split between, well, no and yes, and unsure, even being the no and yes. But 41% for yes, they've treated a transgender patient, 34% said no, and 22% said unsure. One of the other questions was, do you feel comfortable treating transgender patients? 65% of you said yes, which is great. 27% said unsure, and 3% said no. So I appreciate you guys' honesty in answering these questions. Again, this is sometimes can be an uncomfortable topic, and I think it's great that we're talking about it today. And last question was, have you ever received training on treating a transgender patient, which I thought this was really, really interesting. 88% of you said no. So I think today is, again, there's just that much more information and more emphasis on why we need to have trainings like this. And I appreciate Taylor coming to talk to us about this today. So without further ado, Taylor, welcome to the webinar.
Thank you. Thank you for having me. Yeah, so you might be asking yourself, why are we having this training now? The reason why we're having this training now is that in the state of Oregon, our insurance companies are covering all surgeries. So no matter where in Oregon you are, you can have a transgender patient that's having a complication. And I know like what I talk about can make you uncomfortable. But it's okay. My name is Taylor Sprecher. I've been in EMS since 2006. I own my own training business, and for the last 9 years, I've been working for AMR, responding to 911 calls in Clackamas County. I'm also part of our emergency response team. In 2017, I was deployed to the California wildfires. In 2018, I was deployed to Hurricane Florence and to Hurricane Michael. I started hormones, testosterone in August of 2012. I had my top surgery, which is a double mastectomy, on June 2nd, 2016. And then my medical transition became complete when I had my hysterectomy on January 2nd. When I was 15 years old, I came out as a lesbian. Also at the age of 15, I had a breast implant because one of my breasts grew and the other one didn't. At the end of this webinar, you guys will have a copy of the reference guide that I made for transgender patients. And also, I just want you to know that, I'm not trying to change your mind on how you feel about transgender people, and I really don't care what you think about transgender people. But what I am asking is that when you have a transgender patient, is be aware of what your own biases are and use their chosen name and chosen pronouns. And again, if you have any questions during this training, just please ask. The only wrong question is the one that you didn't ask. And so we're continually being told to not ask questions about genitals or surgeries to transgender patients, but sometimes in the emergency setting, we have to know these things in order, if a trans male is pregnant, then we're not going to get lost on the fact that, hey, yeah, they're trans, but they still have parts where they can be pregnant. And also some of the language that I talk about today is also going to be added into the Metro Regional EMS Consultorium Patient Protocols for 2020. So when I talk about 12 leads, 12 leads in the gender, that's going to be added, or language added for the chest pain. Abdominal pain is going to be make sure to rule out pregnancy in trans men. And then also the pronouns will be going into universal patient for both Clackamas County and Washington County protocols. So the objectives of this training is to get terms associated with transitioning. You'll know what the DSM WPATH and what the criteria is for diagnosis of gender dysphoria, pronouns, how to ask questions regarding legal name change, any surgeries, all medications that a transgender patient can have, a brief overview of all the surgeries that a transgender male or transgender female can have. I have a chest pain scenario, I have an abdominal pain scenario, male to female, a vaginoplasty scenario, and then the pre-hospital rate report, reports to the nurse, and charting. I'm trying. Okay. When we're talking about transitioning, there's three types of transitions that a transgender patient goes through. Social transition, which is coming out to your family, to your friends, co-workers. The medical transition, that is you starting going to therapy to getting diagnosed with gender dysphoria and taking that letter that you get from the therapist to your doctor, having them prescribe hormones, and then having them write the referrals to you for top surgery or for bottom surgery. And then there's legal transition where they do court order name and gender change. You change your driver's license, Social Security, and birth certificate. I know for me, I just recently changed my birth certificate. For when I had to change my name, I had to go to Clackamas County Courthouse and I had to fill out this paper, and then it had to be on the board for 2 weeks. And so if anybody objected to you changing your name, then they can file that objection, then you could go and have talk with the judge. But for me, that never happened. And my birth name, for me, I was born as Jeannie Sprecher, and I was named after my aunt who was murdered by her boyfriend in a drunk driving accident. And so because I knew what my name meant to my mom, I kept Jean as my middle name just as a way to still honor my mom's aunt or my mom's sister. And we're talking about gender pronouns. It can be she, her, hers, he, him, his. The one part that's new that people might have a hard time is when a patient refers to themselves as they, them, or theirs. And what's good is they are speaking. I listen to them. The backpack is theirs, and the singular use of theirs has been around since the 1300s, but it just recently has gotten out of the English language. I don't know what happened. For non-binary adults, it could be the new, instead of Mr. and Mrs., it's going to be MX, and then that we pronounce mixed. So the mixed tsprecher. So, and you might be like, well, I don't want to call the patient by their preferred pronouns. You know, they don't look like that gender, you know, but what this is showing is that the known cases of violence against transgender people is 29 for the high of 2017. And this breaks it down from trans men to trans women. And then the other slide is white or the ethnicity. And you can see that trans women of color have the highest rate of violence against them. And the life expectancy for a trans woman or a trans woman of color is 35 years old versus a cisgender African American woman is 75. So you never know what your patient has gone through, and if they were just assaulted, they're not going to want to have a provider that's not going to refer to them as their pronoun. Whoa. So when it comes to terminology, it's cisgender, gender expression, gender expansiveness, gender identity, gender dysphoria, gender nonconforming, intersex, female to male, male to female, non-binary, agender, bigender, polygender, genderqueer, two-spirit, AFAB, and AMAB. I go into all of these about what it is. So cisgender is basically you identify as the sex you're assigned with at birth. Gender expansiveness is just a more wider, flexible range of gender identity and expression that's typically associated with the binary gender system. And when I say binary, it means what is male, what is female. And gender expression is basically how do you present yourself and what does so they see you walking out on the street and you present as male, and so that's what you're showing society is how you reflect. Intersex, there's 4 different types. There's 46XX, 46XY, there's true gonadal intersex, and then complex or undetermined intersex. So basically they could have a phallus, they could have testicular tissue, ovarian tissue, uterine tissue. They can also have 45 XO chromosomes, whereas only one X chromosome. They could have 47 XXY and 47 XX. Intersex, the old term for that is hermaphrodite, but now they refer to it as intersex. So there's different stages. If it's male and they have a phallus and a scrotum, they don't leave it alone, or they just leave it alone. For a female, they check and do they have like the prostate gland present? Do they have a vaginal opening? And so that will be stage 0 through stage 4. So then how do they decide if they're going to make the baby a male or female? They use a ruler, the fallometer. So basically if it's less than an inch, if the clitoris is less than an inch, then they're going to make that baby a female. If it's over an inch, they're going to make that baby a male. So female to male is a man who is assigned female at birth. And that was me. I'm a female to male. Now, female, a woman who was assigned male at birth. Non-binary is just a spectrum of gender identities that's not exclusively masculine or feminine. And it's basically identities that are outside of the gender binary. And when we're talking about non-binary, so Oregon, we can change our driver's licenses to X as their gender. So this is the old driver licenses. So it has the sex of X, and that's what it looks like when they're non-binary. With the new driver's licenses, you can see on 15 that there's an X right there for sex. And so even if your charting systems, if they do not have the option for X, they need to get changed to reflect how somebody can identify here in Oregon. The agender is basically they identify with having a gender. By gender, they can be masculine, feminine, agender, androgynous, any two of those identities, and then they'll identify simultaneously as those. Polygender, many different genders that they can identify as. It could be binary, it could be any of the non-binary. Genderqueer is denoting a person that just doesn't subscribe to the conventional gender stereotypes. T-spirit is the modern umbrella term for used by the indigenous North Americans to describe gay, lesbian, bisexual, gender-variant individuals. AFAB, assigned female at birth. I go in and I use these definitions, AFAB and AMAB, which is a male assigned at birth. And then also when I say trans men, I'm talking about female to male. And then when I talk about trans women, I'm also talking about male to female. And so this is the DSM-5, the diagnostic. This is how somebody is identified or diagnosed with gender dysphoria. And so this has for children and also has it for adults. And for this, just because a child has some of this, does that mean that they're gonna grow up and they're gonna be trans? No. This is for the kids that have continued identified as transgender and has not ever gone back on that. And there was a study that was done in the Netherlands where this neurologist did a MRI of 163 kids. Some of them identified as trans male, some identified as trans women, some of them were cisgendered. And what they gave the kids a toy and they did an MRI. And what they found is that the kids that identified as transgender, that their brain and that gender part of their brain matched the kids who were cisgender. So basically it matched the gender that they identified as, which I think is pretty cool. The WPATH, that they set the standards for transgender patient care using evidence-based education, research, and advocacy, public policy, and respect for transgender health. The standard version just came out with 7. The standard version 8, they're going to get rid of the requirement to have a letter to start hormones, so you just have to do informed consent. And so with the letter, the therapist has to, it's a letter from one mental health provider, the persistent, well-documented gender dysphoria informed consent capacity. So for the state of Oregon, it is 15 years old. So they can consent to being on hormones, but they cannot consent to having surgeries, and they would have to have a parent, the parents would have to sign consent for them to have surgeries. But when they do informed consent, they have to make sure they know what they're getting into, the benefits, the risks, the impact on reproductive health. So when we're talking about top surgery, it's either for trans men, it's going to be a double mastectomy. For trans women, it'll be breast implants. Are you able to give informed consent? And then, so it's 1 letter for top surgery, and then when the hysterectomy and orchiectomy and like that, you have to have 2 letters from 2 different therapists before you're able to go and get a referral to a gynecologist. When you're asking general questions,
Sorry, Taylor.
Oh, it's okay.
Hey, back on slide. I can't remember if you covered this or not. It's pretty quick. Does insurance cover reassignment surgeries? Do you know?
Yes. Yes. Now in the state of Oregon, even if the company has a clause on there saying that they're not going to cover any gender-related care, then they will still cover it. So like for me, AMR has a policy where they're not going to cover any gender surgeries. But when I was getting this ball rolling, I wrote a letter to our executive officer. He forwarded it to our human resources guy. And he was just like, if you want to have your surgeries, you're going to have to bargain for it in your union. I'm like, okay, well, there's more important things to fight for than for this right now, you know? And then in 2016, Oregon, that law finally went into effect where even if you have exclusions. And so when AMR's corporate HR guy, when he got that letter from Kaiser, then he called Kaiser to have them call me to tell me that my surgeries were going to be covered under our insurance. So,
That's awesome.
Yeah. And
just to let everybody else know too, there's a lot of information on these slides, and they are going to be available if you email me at the end of the presentation. So if we're going through stuff kind of fast and you can't read it all, it's recorded, and Taylor has made it available, so you can get it afterwards. Thanks,
yes,
Taylor.
and also I can also come out to your firehouse and do a training too, and to do in person for all of your employees. Okay, so asking pronouns or asking questions, what pronouns do you prefer? And then sex assigned at birth, we assign male or female at birth. Have you changed any legal documents? This is important for charting to make sure that we have a chart that's going to be accurate for billing, but then it's also going to reflect how the patient identifies. And then for adolescents, have you told your family that you're transgender? We want to ask them outside of earshot from their parents because we don't know what the family dynamics are. And if we say something in front of the parents, then that child could get kicked out of their house. And then name change in the hospital. Does the hospital have your chosen name? Sometimes if the hospital doesn't have, then you'll have to ask what was just the name given to them at birth. You might be uncomfortable having this conversation with your patient, and I can tell you that one of my most uncomfortable conversations that I've had before is asking my dying father why he's scared to die. And for him, it was the nothingness that is death. And I didn't know how to respond to that or respond to him to help alleviate his fears. And when we're talking about hormones, puberty blockers that they can take is leuprolide acetate and histoline acetate. And basically, they are gonadotropins or agonists, gonadotropin-releasing hormones. And so the leuprolide, they affect the luteinizing hormone and the follicle-stimulating hormone. It's metabolized into small peptides and eliminated through the urine. They can have angina, PEs, MIs, dysphagia, anxiety, nervousness, syncope, ecchymosis, bradycardia, stroke, TIA, auditory hallucinations. The brand names for leuprolide is Lupron Depot, and then the different months, 6, 3, 4 months. The histoline acetate is the same thing. So basically what's the difference between the two is the leuprolide is a injection that lasts for a month, and then the histoline is about a size of a dime, pea size, that will go into the arm. And what's important to also realize about these is that just because a child is taking the puberty blockers, that right as soon as they stop taking it, then they will go through their normal puberty, so we're not doing any harm by them taking these hormones. And again, the same thing you put a history in, the MI, sudden cardiac death, stroke, hyperglycemia, emotional lability, irritability, anger, aggression. The male to female, yeah.
Hey, sorry. Do you know if anywhere in the timeline of taking those hormones, there's more risks of side effects, like beginning them or kind of in the middle, or does it not?
I honestly don't know. I just think probably like from the beginning that like these are the effects that could happen up until the time that they stop them.
Okay, so it doesn't really show an increase of when they first start taking them or anything like that. Okay.
Yeah.
Thanks, Taylor.
No. Yeah. The male to female medications is estrogen, spironolactone, or progesterone, which most of them are not taking progesterone. A lot of trans women take Spiro, and then also finasteride. So this one is estrogen. The estrogen are responsible for the development maintenance of the female reproductive system and the secondary sexual characteristics. With edema or with estrogen, they can have edema, hypertension, CVA, dementia, a headache, and also it can mask, estrogen can mask the migraines. So just have it on your index of suspicion. If somebody's having a headache, it could be a lot worse than what they portray it is. Some of the brand names, Allura, Chimera, Delestrogen, and the depo-estradiol. The most ones where I've seen is the depo-estradiol is the main estrogen that the trans women take. Changes from estrogen, permanent changes in breast development, enlarged nipples, stretch marks. The temporary changes to the redistribution of fat, reduced muscle development, decreased libido, reduced gonad size, less prominence of the veins, possible hair growth in the balding areas. Eyebrows may become less bushy. The spironolactone it competes with aldosterone for receptor sites in the distal renal tubules. The one thing that you need to be careful with patients that are taking the spironolactone is that if they're also taking any NSAIDs, is that's going to increase their risk of hyperkalemia. So if you come up to the monitor and they're showing signs of hyperkalemia, then start treating them for the hyperkalemia. Changes from the spiro, lowers testosterone level, decreases facial and body hair growth, decreases progression of the male pattern baldness. Mild breast growth, which is also irreversible, it allows the estrogen to have a more pronounced effect. And it also decreases the conversion of testosterone to dihydrotestosterone. Finasteride, it blocks the action of the enzyme called the 5-alpha reductase, that's the enzyme that changes testosterone to dihydrotestosterone. And one of the bigger things with this is that it can cause orthostatic hypotension, dizziness, decreased libido, impotence, edema, drowsiness, gynecomastia. And then finasteride changes. It raises the estrogen levels, reduces conversion of testosterone to DHT, regrows hair in thin areas, and then slows down or halts hair loss. The FTM medications, testosterone, and then they can also be having an estrogen ring or a cream. I take both. I also have an estrogen ring because being on testosterone, it dries out your vaginal wall. And so any type of penetration or anything that it'll make you bleed. So the estrogen ring allows the estrogen to moist and stuff. So testosterone is basically responsible for the development of male sexual organs and maintenance of the secondary sex characteristics. The adverse reactions is male pattern baldness, heart attack, retention, sodium chloride, water, calcium, potassium, and inorganic phosphates. nausea, TIA, PEs, cardiac arrest, hypertrophic cardiomyopathy, CHF, CVA. So just when you have these medications, just be on a heightened alert that like it can increase the risk of stroke and heart attacks. The testosterone changes, thickening of the vocal cords, facial hair growth, increased body hair, increased body musculature, mitigation of body fat to a more masculine pattern. Skin may become rougher in feeling. When we're talking about surgeries for transgender women, these are some of the common surgeries that they have. One is for the face. One of my questions is that with the chin and jaw recontouring is that it takes out the angle of the jaw. So is that going to affect the size of NPA or OPA that we put in? If they have that, the only way really that we'd be able to know is if we have the surgeons do a measurement before they do the surgery and then after they do the surgery to see is that shaving of the is that really going to matter? You know, the only way is if we study it. And then they can have a tracheal shave, which the tracheal shave is just basically shaving the thyroid cartilage down to decrease the size of the Adam's apple and to make the throat appear more feminine. And one of the risks for tracheal shaves is the blood loss, edema, and then any hoarseness or pitch drop that lasts longer than 7 days could be because of the anterior commissural detachment. And if the detachment is left untreated, then it could result in scar tissue in 6 to 12 months. And so when we're talking about the anterior commissure, this part is the area of the glottis anteriorly situated between the two vocal folds, inserting into the thyroid cartilage. So that's the part that can become detached. And so then if there's extra scar tissue, then you're going to need to think, if you have a patient, you know that they've had the tracheal shave, and you know if you're going down a road where you might have to intubate them, then have a backup. Have maybe 1 or 2 backups for the airway. Vaginoplasty, there's 3 different, well, there's a penile version, which it takes the shaft of the penis and it uses that skin to create the vaginal wall. The rectal sigmoid, they use part of the sigmoid colon to create the vaginal cavity. And then there's a perineal pull-through, that was the surgery that they've created for intersex babies. Complications, in 2015, a study concluded that the most common complication was the narrowing of the vagina, changes in the urine stream, tissue necrosis, rectal injuries, and with the rectal sigmoid colon technique specifically, divergent colitis and adenocarcinoma of the neovagina is what can happen. And with one of the questions that I had was if we had a transgender patient, one of the risks is that the sutures can split. So can we use combat gauze to stop the bleeding? And one of the answers that I got is that if we use the combat gauze, it's going to cauterize any tissue that could be used for a graft later on. And so they suggested to use an abdominal pad to stop the bleeding. And then if you're in rural Oregon, then take them to the hospital that you take them, somebody like having a heart attack or a stroke or somebody that's capable of doing that stuff, because then maybe they can stabilize them and then get them transferred to up here. Because most likely in the state of Oregon, the phalloplasty and vaginoplasty is done at OHSU and at Good Sam. These are a preoperative if they haven't had a vaginoplasty yet. These are what gasps look like. And basically, the shaft of the penis gets put through the ring, and then it gets pulled back, and usually the phallus will sit in between the butt cheeks. And then when the testicles will be going into the inguinal canal, and a preoperative trans woman could also have breast forms on. So when you're doing a trauma assessment, that these are the type of items that you can find on a transgender female. Female to male top surgeries, these are all double mastectomies, and basically the style, these are all going to be based on the type of breast size that the trans male has. So for me, I had the double incision with nipple grafts and then an inverted T because the implant that I had when I was 15. And these are pictures. This one is me right after my surgery. I went in at 6 o'clock in the morning, and then by 11:30 I was at home. And then when this one is my chest reveal, that was the first time that I saw my chest without all of this on. These will stay on for a week to allow any extra blood or anything to come out. And then with the nipples, this is normal for them to look like that. And so it probably wasn't until about a month and a half that it started to go back to normal pink color. With binder, if a trans man hasn't had any top surgery, these are the binders. This is what they look like. And binders are to trans men what leathers are to bikers. So you're doing a trauma assessment on a trans man, don't be so quick to cut off their binder. These are very expensive, and they can be full length, and then these look like the size of sports bras, and they can have the straps to where you might be able to just take it off that way. Possible complications with binding: broken ribs, shortness of breath, back pain throughout the back and the shoulders, increased pressure or increased pain with or pressure when they take a deep breath. And then also it can have a pneumothorax. So binders are to trans men, but the other side of bikers, don't be so quick to remove them. It doesn't matter how much pain. We've been on scene where a biker, and it doesn't matter how much pain they're in, they're still not going to let us touch their leathers. You'll do the same thing with trans men. And then also, it's the material that binders are, think of Spanx, that's nylon and spandex. The hysterectomy, I had the total hysterectomy with the bilateral salpingo oophorectomy, which basically removed my uterus, my cervix, my fallopian tubes, and my ovaries. And also because of that, for the rest of my life, I'll have to be on testosterone or an estrogen to help with the bones. When we're talking phalloplasties, these are the creation of a phallus for a trans male, and also it includes urethral lengthening and testicular implants. So there's a suprapubic phalloplasty, which there's a pedicle flap, which is they leave the tissue, the blood vessels, the nerves, everything together, and then just reattach it in a different area. And then there's a suprapubic, and then there's also a groin phalloplasty, which is on both sides of the abdomen. They take stuff from on the abdominal, where it's the middle. The radial forearm flap, they take the muscles, the nerves, the blood vessels, everything from the forearm, and then they reattach it. With this, you want to ask them if there's any deficits that they received from having the surgery, because if you're going on a patient that is having a stroke and you see that they have a deficit, then you want to know, is this something that's new or is this something that they've already had? And then there's also the latissimus dorsi flap, which just uses the subscapular artery, the branch of the serratus, and use the distal muscle. That's a lateral alt flap, which is they're using the lateral, so they use the lateral circumflex femoral artery. So they can either keep it connected, or they can take the muscles and everything and do a free flap off of that. The risk of risk of phalloplasty, urethral-fistula, urethral stricture, flap failure or loss, fluid breakdown, pelvic bleeding or pain, bladder rectal injury, donation site risk, unsightly scarring or discoloration, tissue granulation, decreased mobility, bruising, decreased sensation, pain. Methodioplasty is just basically they're using the testosterone besides clitoris, and they're cutting the ligament that's holding it up, and it allows that to have a more natural penis looking. So if somebody hasn't had a phalloplasty or methodioplasty, that they could be wearing a packer. And the packer, it could either look like a harness like this. The underwear, they could have a extra pouch onto it. This right here, that's the STPs. Basically allows us to be able to stand up at the urinal to go pee. And these are different colors that the packers can come in. It was spinal injuries because the packers and the STPs, they create a bulge. Is that if you're checking for priapism, this isn't going to be a accurate assessment for them. And then we can put up the poll.
Yes, thank you. We're going to launch a poll for everybody here. So how important is it to set the cardiac monitor to the birth standard when performing a 12 lead on a transgender patient? Give everybody just another 20 seconds or so. And while we're waiting on this poll, Taylor, there's a medication question we can either do now or we can wait till the end.
We can do it now.
Okay. Somebody was asking about, are there any potential interactions with any of our typical EMS medications when patients are on different hormones?
There's been no study of that, so I wouldn't be able to answer that question.
Okay, so nothing that you've heard of yet? Okay, that's perfect. Thanks.
Yeah.
And it looks like a fair amount of people have voted. Go ahead and close this out just so we can save time here. And these are the results. So very important, 21%, somewhat important, another quarter, 12% not important, and then a good portion of the class doesn't know. So it's great that we're going to go and talk over this.
Yeah. So you arrive on scene and you have a transgender male that's having chest pain. That's what the poll question was. Does it matter what gender you set the monitor to? It does, because in order to get the axis of the heart, which is measuring the average direction of ventricular depolarization during ventricular contraction, from male and females, that axis is different. And then you can ask them, where do you assign male or female at birth to be able to catch? You're asking this because if they are having a cardiac event, you want to be able to catch it. So this is a 12 lead of a 29-year-old transgender male who was having chest pain. This particular 12 lead was done at male. You can see that the P-axis is 44. the QRS axis is 52 degrees, and then the T axis is 45 degrees. And then this is a 12 lead of that same patient, but with the gender done as female. And you can see the T axis is 66 degrees, the QRS is 78 degrees, and the T wave is 39 degrees. So the difference between the male and female axis is, for the T waves, just based on these two, was 22 degrees. The QRS was 26 degrees different. The T wave only was a 6 degrees different, which I thought was interesting, and that a female assigned at birth, the axis of the PQRS is greater than a male assigned at birth, whereas the T wave axis is greater in a male assigned at birth versus a female assigned at birth. And so for, and also another condition, left ventricular hypertrophy, which the EKG for diagnosing this is very insensitive, which is 50% can be diagnosed in patients. But if the criteria is met, then it has a specificity of 90%. And LVH strain can mimic a STEMI. And so to be able to know, is this LVH or is this going to be a STEMI? That's what we need to know. And so for the criteria that's best used for bedside clinicians is using the Cornell voltage criteria, which is basically saying that the S wave, or the SMV3 plus the R wave in ABL is 28 millimeters for men and 20 millimeters for women. And so by having this criteria and knowing that there's such a huge difference between the male and female, that it's better to be using the gender assigned at birth for a monitor that has gender specific criteria to diagnose a STEMI or anything. And that's going to be the language that is going to be added into Clackamas County and Washington County protocols in 2020. So there's a little M&E series, which doesn't have age or gender specific criteria. Right now, I believe Hood & Fire is the only one that has these, but they're going to be phasing them out and going to the Zol X. And so for that one, you don't need to worry about selecting a gender for chest pain. BlackPack 15, they use the University of Glasgow 12-lead analysis algorithm. They do have age and gender specific criteria, so gender needs to be gender assigned at birth. And you know, like when you're explaining that to somebody, it's just like you tell them you're not trying to disrespect who they are. It's just that if you are having a critical cardiac event, we want to be able to catch it. The Zol X monitor has the Invoice 12L analysis algorithm, which is gender-specific criteria for LVH and STEMI, so gender needs to be gender assigned at birth. And the Philips MRX monitor has the DXL version PH100B EKG algorithm. It does have the sex and age criteria for STEMI and LVH, so it'll be gender assigned at birth. With the vaginoplasty, the sutures can split, and so this is using the abdominal pad to control the bleeding. And definitive care is going to be the hospital where the surgery was performed. We're not going to take a cardiac patient to a hospital that doesn't have a cath lab. And so for trans males having abdominal pain, you want to ask, have you had a hysterectomy? If no, are you sexually active with men? If it's yes, do they use protection? Do you still have your menstrual cycle? Are you current on taking your testosterone? So the reason why this is in there is there's already been a case here in the United States where a transgender male has gone into the ER, and because his electronic chart was, his gender was changed to male, the nurse didn't have the proper training to be able to ask more questions, but he came in there and he said that he took a pregnancy test that came back positive. A little while later, he felt like he peed himself. So that tells me his water broke. But the nurse wasn't able to comprehend that, like, she sees the gender marker as male, and they're not, if a cisgender woman was to go in there, then, and say that stuff, they'd automatically get taken back and get worked up for being pregnant, and the doctor would evaluate them, but this patient ended up getting sent back into the waiting room, and the cord ended up wrapping around the baby, and the baby ended up dying because it didn't get taken back right away. And so for this, there's already been a case for a transgender man trying to go and get health care, and the baby ended up dying. But there hasn't been anybody that's missed a heart attack because the wrong gender was assigned on the monitor. And really, like, that's what I want to prevent. I don't want there to be another story like the man having abdominal pain going into the ER. When you're giving a report to the hospital, use the pronoun that the patient prefers. You don't have to tell them that they're transgender here. If you feel like you have to say that they're transgender when you're given the radio report, then make it consistent. And with every single patient then say you're bringing a cisgendered female or a cisgendered male into the ER. And so an example is medic 35 en route with 38-year-old male complaining of abdominal pain, blood pressure is 146/94, 110 sinus rhythm, GCS 15, 18 gauge, IV established, 100 micrograms of fentanyl on board, ETA 20 minutes, any questions? If they don't have any questions, and then it's when you're doing the turnover to the nurses when you want to tell them that the patient is transgender. And so example is Taylor, he's 38 years old, transgender male complaining of abdominal pain. Your patient stated that January 2nd he had his total hysterectomy. Yesterday on 4/28 he stated that he and his partner had penetrative sex that was rougher than normal. During the day the patient slowly developed abdominal pain. During the night the patient was able to sleep because the pain was so bad. And then when I woke up in the morning, the pain was 10 out of 10, with positive for rebound tenderness. So this scenario, that's really me. Me and my partner, we did have everything that was stated, but instead of me calling 911, I called my gynecologist, and when I went into to her, explained everything that happened. When they were doing the exam, they said that everything was fine. What they were afraid of is that I could have had a vaginal cuff tear, but it wasn't. So then I drove myself from Salmon Creek up in Washington to Kaiser Sunnyside because I wasn't going to call 911 or go in by ambulance. And then at the hospital, when they did a CT, they found that my sigmoid colon was inflamed, my ileum was inflamed, and then I had fluid inside of my abdomen. And I knew in order for me to get the proper treatment that I had to, no matter how embarrassing it was for me to say all of this stuff, but I knew that if I was going to get treated properly, that I would have to say this. And so healthcare is going to have to be on both the transgender patient being honest with you guys and you providing them the space to be able to be honest too. In charting in the patient demographic, you put the name and gender that's on the government ID. So if they so for me before I changed my ID, you would have put Jeannie for the name, and the gender you would have put female, and then transgender goes in the medical history. In the narrative, you can make a statement. If the legal ID and stuff hasn't been changed, you make a statement saying that the patient goes by Taylor, uses male pronouns, and going forward, I would refer to the patient using those identifiers. Now, there hasn't been any sort of discrimination lawsuit brought up against an EMS company for them not respecting the pronouns or referring to the patient like that. But if this was to go to court, if it's not on the chart, we didn't do it. And so could this be used as proof like, hey, no, I really was respectful and I was conscious about how the patient identified. And so the gender affirming surgery hospitals here, Tallahassee, Vaginoplasty, orchiectomy and hysterectomy is OHSU and Good Sam, and then top surgery and hysterectomies Kaiser, Providence, Portland, and Good Sam. So the key takeaways, patient care begins with using the chosen name and pronouns. If you misgender them, it's okay, just correct yourself and move on. Spironolactone and NSAIDs equals hyperkalemia. So if you notice the hyperkalemic on the monitor, treat per hyperkalemia. Estrogen can mask migraines, increases the risk of CVAs, PEs, and MIs. Finasteride can cause orthostatic hypotension. Testosterone increases the risk of CVA, MIs, PEs, psychosis if the T levels are too high. And another thing, I don't know if my testosterone levels are too high because I've already had my hysterectomy, but when I didn't have a hysterectomy and my levels were high, then it would have converted back into estrogen. And so that would have basically negate everything that I was trying to do. So we have to get blood work done fairly regularly to check our testosterone levels. For chest pain calls on a transgender patient, use sex assigned at birth for sex designation on a 12 lead if the algorithm has gender-specific criteria. And then trans female bleeding from a vaginoplasty, use an abdominal pad to control the bleeding. If a patient hasn't had a legal name for charging purposes, use the name that's on the government-issued ID, but then in the narrative, make a statement saying that they're transgender, uses male pronouns, or will use whatever pronoun. And then going forward, I'll refer to the patient as such. That way that makes the chart accurate for billing and respects how the patient identifies. And then not all transgender people are going to have surgery or want to be on hormones, and it doesn't matter if they don't have any surgery. If they say they're transgender and uses these pronouns, just respect that and refer to them as how they would want to be referred to as. That is it. Is there any other questions?
Perfect timing, Taylor. I think that was right. Amazing, all of it. You got through all of it. I'm impressed. You kind of hit on it at the end. A person's asking, are most trans patients going to tell us up front that they're trans, or are you finding that it's situationally dependent, like you were saying earlier, if there's different members of the public around or family or a bunch of people on scene, they might not be as open to saying it until you get in the back of the ambulance? What's your take on that?
Correct, yeah. I've had people tell me that they're trans, and then if they tell me that they're trans, then I also out myself to them also, just so in that way they can feel comfortable talking to me. And really it's just going to depend on, it's going to be independent on whether or not they're going to feel comfortable telling you or not.
Sure. So doing your best and asking, maybe documenting too that you've asked the question and the patient refuses to answer.
Yeah.
Yeah. And I was thinking to myself too, it's something I think that might just have to change and take time to change when getting comfortable asking every patient what was your gender assigned at birth. I remember when we used to ask female patients if they were taking any erectile dysfunction medication, and before going down your chest pain protocol, and I would have a lot of women look at me and kind of with an odd face saying, why are you asking me that? Just because it was a new thing that a lot of women were starting to take those medications. So I think it's just something that has to it's going to take some time to change. But I don't think, like you said, if we do it with every patient, it's just to keep that patient and yourself safe. Taylor, do you have a slide with your email address on it? Was it the first slide?
Oh, I do not have. It's tsprecher@gmail.com is my email.
Sure. Let me send that to everybody.
Okay.
Was it Taylor.Sprecher or just all one word?
Yeah, it's all one word.
A Gmail? Okay. Someone was asking about having a presentation at their department. So you guys can reach Taylor at that email I just sent.
And this is, honestly, this is the first training out there to actually have treatment options for transgender patients. And so that's what's also really exciting about this, is that we're on the forefront of getting this information out there.
No, I think it's great. And I know that OHSU, there was just a report in NPR recently that they're starting to train all of their nursing and medical students on transgender patient care, and they're one of only 6 hospital-based education agencies in the country that are doing it. So Oregon's really on the forefront for this education, which I think is awesome.
Yeah.
Also, we'll wait to see if there's any other questions coming in. Give everybody another minute or so. I also want to highlight that you are presenting this nationally next month at the National Ambulance Association in Nashville, which is very, very exciting. So
it is. We have a general session which up to 800 executives can be there. I'm doing it with Scott Moore, who is a EMS consultant for the American Ambulance Association and also consults on HR policies. And so we're doing it on what can companies do to create a more inclusive environment for transgender coworkers, and then also this about treating transgender patients.
Yeah, that's awesome. And again, a reminder to everybody, there's a handout that Taylor provided with several pages of great information and an example of the protocol changes that are going in Clackamas and Washington Counties. You can definitely take those and take them back to your agency and see if you can adopt any of those into your own protocols. And again, we've put up Taylor's email. If you guys have questions, you can email him directly. Again, he's also said that he's willing to provide training, which is awesome. This is going to be recorded and put up on Oregon iLearn. So if you guys want to watch it later and you don't have access to that, you can find it on our website, how to create an account on iLearn Oregon and watch it. And if not, you can email me. I'll go back here and put up my screen so you guys can see my email. You guys should all have it. Back there somewhere. See if there's any more questions.
And also, if you guys have, if there's anything else that you'd want to see in this training, also feel free to let me know and I can add it. My whole goal with this training is to basically take the taboo out of transitioning and having transgender patients.
Okay, I don't see any other questions, Taylor. Again, I really appreciate it. Thank you for hosting. There's my email, you guys if you have questions. And again, we'll talk to you guys and see you guys in November with Infant Safe Sleep with Dr. Rostigas. Thanks again, Taylor.
Thank you.